though he was party to this, and the documentation there is what it says in the 10. What's very interesting about this is that if you look at the documentation and then correlate it with the report of the colposcopist meeting, and you'll see that within the discussion there, Chair, 6 months. And do you know what they achieved in 6 months, lads? They set up a briefing note for patients. A leaflet. A leaflet for patients was achieved within 6 months. And the leaflet for patients, which I'll read at the end, remember, Vicky Phelan is one of these. It is envisaged that the woman would be able to tear off the notification slip and send directly to the cervical check programme to opt in to receiving this information. Open disclosure. Opt in. Tear off a slip after 6 months. And we now know 80% of women not being told. This was the conclusion. How does that make you feel, Mr. Conaghan?
Well, first of all, I'm going to have to read the 30 pages to give you a better answer to that, and I think certainly the Scally review will really have to take a look at processes. What you're highlighting there is, was there a process failure in relation to how we're going to communicate that?
Also inside in the documentation, I'll cut it into it because you haven't read it. It's also made very clear that there are discrepancies in lists in cervical check.
Yeah, is there an appendix number in the top of the page?
There's a whole range of them, yeah.
Is there an appendix number in the top of the page?
No. Trust me on this, I've taken notes. I only got them at lunchtime. Okay. Right. Discrepancies in the lists that were provided. So, we're talking about the middle of last year on, and they were taking months even saying that the list provided to clinicians to be told were not accurate. So how could they tell them, even if it was the right process, which it wasn't? Cervical check did it, so it should have told them. When they provided the list, they weren't even accurate in the first place. So how could they?
So that communication needs to be double and triple checked. You're absolutely right that if we've not got the right lists, then how can we actually inform patients appropriately?
Also the correspondence on the 13th of July to all the other general managers across the HSE. I know most of them myself. What did they do? And actually, did this come to a head because, in fairness, to actually say something complimentary, maybe they basically took the lead and said, lads, this has to get sorted. We're going to have to chase that and find that out. Will you return to this committee the information in relation to what they did? In other words, basically do what Limerick did and send us on a chronology and documentation similar so we can see what all of them did. When it comes to the documentation that's provided in the booklet for clinicians, it says next steps. In cases where women have died, simply ensure the result is recorded in the woman's notes. We also see it in the draft letters. The Criminal and Justice Theft and Fraud Offences Act 2001 has come to mind when I read this. Not providing information like this, it needs to be investigated, Chair. It needs to be investigated under that Act, in my opinion. And I'm saying that as softly as I can. Because if you read through that Act, not providing this information to those people, to those next of kin, and delaying it. And we had one of the families sitting here yesterday, Stephen, not providing that information. We all know now it's a disgrace. We all know now that open disclosure might backside. But we all know now, we also should look at it under this premise. When it comes to the information that has been provided, I would encourage people who are watching this to consider coming forward. We're not being provided all information, Chair. I have a whole range of other questions. We're not being provided all information. I would ask people who are watching this to consider the Protected Disclosures Act, or the legislation, to consider even providing it to us or to the Chair of the Health Committee, maybe, whichever, to come forward, because I believe there needs to be a process by which this information is brought forward, and this is an absolutely critical point, brought forward through a process, a protected process like the PAC, Health Committee or something. Because there are people in the HSE who are remaining in positions, and to use a phrase that was used earlier on, they have skin in the game. They're in positions. And Stephen asked yesterday that they be stood aside without prejudice, or stood aside, I'm using the bit without prejudice, because obviously some people may not want to come forward while that's the way it is. And Mr. Conaghan, I've been on a team about this for 2 days with you. I pray and hope that you are listening to me, because I don't want the whole process around Scally to be in any way, and I use this in inverted commas because I can't think of another word, corrupted by the fact that these people aren't coming forward and that people have remained in positions who are part of the issue here.
Can I supply one piece of information that you asked me for already this morning, if that's okay? I undertook to check with particular reference to Mr Patrick Lynch's leave arrangements. Okay? So I did that in 2 ways. First way I did was to access his annual leave card. That had actually been signed off, as I thought, by the previous Director General. Okay? There is no date appended to the signature. However, I further checked with Mr Lynch about when he actually booked his flights. He booked his flights on the 17th of January. So I am estimating that his leave arrangement was made and agreed prior to that date.
It wasn't signed off.
It was signed off.
But you said there was no signature.
Oh, there is a signature, but there's no date beside the signature. The way the leave card works, you've got a signature to say approved, okay? But there's no other
Listen
thing.
to me.
However, just to make sure that I answered your question truthfully and honestly, went back to Mr Lynch on holiday and found out when he actually booked his flights. He booked his flights on the 17th of January.
Okay, can I just say this to you, to the public watching out there? They don't care about this. What is more worrying for me is that in order to make this whole jigsaw come together, Mr Woods is gone now, that they weren't here to answer questions. And secondly, what's more worrying for me, as acting DG, is I couldn't care less. Everyone's entitled to their leave. But I'm not going to take leave during a general election because I have to fight it. These are critical people at the highest level underneath you in the HSE, and they're away during the biggest national health crisis in years. That's not acceptable to anybody listening or watching in any way, shape or form. What is the scale range of salary of somebody at directorate level in the HSE?
It varies from between about €100,000 to about €165,000.
Well, I would guesstimate that they're probably at the higher echelons of that.
At director level, they're not.
Okay, but my point stands. The last question in this round, because I know I asked a number of questions. I asked for this information relating to the lead call hospice. We all had to learn that phrase in the last 2 weeks, I think. Lead call hospice groups meetings. So we asked for all the minutes in relation to these meetings. We got ones in October. Why didn't we get the follow-on meetings? The meetings they had with gynecologists. And really, for the journalists who are watching this, will somebody go through the list that is published there and ask why so many of these clinicians at this meeting didn't bother being part of wanting to know the best way of informing the patients concerned? The volume, you see the list, the volume of clinicians who were not party to this is incredible. So I'd ask somebody to go and dig into this. But why weren't we provided with the other minutes and the other meetings?
So, Deputy, I actually checked that out and I got someone to look through over the last couple of days. Obviously, we were here yesterday, but last night they were the only minutes that are there, and the other meeting that I'm aware of.
In October.
The
There
second
was a meeting
meeting,
in
there was
October.
2 meetings, but there was no minutes for the second meeting that could be traced.
And the last question to yourself, what date did you take over from Mr. Lynch?
May 3rd, the Thursday.
No, Mr. Lynch.
From Mr. Lynch, I'm only here since whatever it is, 10, 12 days. So May 3rd, Thursday, 2 weeks last Thursday.
The transfer of responsibility from Mr Lynch to Mr McCallion took place on Friday the 11th of May.
11th of May.
Friday the 11th of
Oh,
May.
yeah, apologies, I was talking the day it started. Apologies.
Friday the 11th of May.
Friday the 11th of May. Mr McCallion started
Amazing.
on the 3rd of May.
When questions started going on about investigator, and I'm using that phrase in inverted commas, being part of the investigation, same time he transfers responsibility. Amazing coincidence.
Well, I think the rationale at that particular point in time, Deputy, is that Mr McCallion has got significant experience with his previous role in emergency management. We took, and I think that if the previous Director General was here, he would have explained this, we took a position at that point that we needed some very senior management in getting a grip of this. Hence, Mr McCallion was called in.
Amazing, because there was a lot of media queries around the same time.
Just one.
Right, we'll move on to Deputy Catherine Murphy, and we will be back. Deputy Murphy.
Right, okay. It just strikes me that my general observation is that there's been kind of an industry of meetings, very poor communications, with a culture really that is very internally focused, where the patient is on the outside. That's my impression. It was interesting last night when we were talking to Vicky and Stephen, that they were looking for the patient to be at the centre of our health service, and that's the only way it's going to be reformed. And there is a mammoth task to do that, judging by what we're seeing here. This is one area. We have so many other areas that we could explore in relation to the health service, but it is certainly shining a light on the processes, the culture, and all of that. And it is a mountain that needs to be climbed, and climbed quickly.
So, David, do you mind if I give a comment on that?
Yeah, can you keep it short, because I've very little time and I've a lot of questions.
Sorry, I'll make a comment after you finish then.
Yeah, okay. We were asked last night by Stephen of the 209 women, and we know within that there are 18 who have died. How many have been diagnosed with terminal cancer? Do you have that figure? I'm asking it because he asked it.
Can we take this query away, Deputy, and have a consideration of the information? Could you maybe just rephrase the question so I entirely understand what you're asking for?
Yes, I mean, there are different, obviously there's different outcomes depending on what time you're told in relation to a cancer diagnosis, and there is, the outcome is very poor the later on, and people are diagnosed with a terminal cancer when there is nothing that can be done, or you're into a different type of experimental medicine. So can you give us some indication of the numbers? Do you have an idea of how many are at the very late stages
So I think what you're saying or asking us to do is, if I take typical cancer progression in 4 stages, stage 1, stage 2, stage 3, stage 4, being perhaps the most severe period in terms of somebody's cancer progression, you're asking us to take the 209 patients, subdivide these into the position for each of these stages for each of the 209 women. Yep. Now, the only issue I've got with that is that we still have patient confidentiality. I would be loath to be able to say that we could automatically provide that if there was going to be a patient confidentiality issue, but I'll look to some of my clinical colleagues for some advice on that.
Just to add to that, sorry, Deputy O'Brien actually had asked for that previously, and we had a discussion on it. We don't capture it at the moment. It's not held in the details. We would have to go back to the hospital and to the patients, just leaving aside the issue of whether people would or wouldn't want to share.
I completely understand about confidentiality, but there's a ratio, some understanding of where we're at. I think without the prospect of identifying individuals is essentially what I'm looking for. I don't want to use up all of the time.
Can
comment just in
Yeah.
a more general
Can you keep it
situation
very
is
quick? Yeah.
that the cancer registry will collect information on the stage at the time of diagnosis, but to my knowledge there isn't systematic measures in place to track progression through changes of whole patient populations or groups. It's just not done.
Okay, so it's not captured. Okay. In relation to open disclosure, and you described just exactly what is required in relation to open disclosure. We've heard the Medical Council guidelines. We've heard that they were updated in recent years. There were clinicians on both sides of this discussion that went on over a year and a half. There was the head of the programme manager for cervical check, which I believe is a doctor, and you had consultants, and there was dialogue going back and forth.
I think the clinical director is. I'm not certain of the terminology, but the programme manager is not a consultant. It's the clinical director that's the consultant.
Sorry, yeah, I'm just looking at the some of the appendix number 14 and the dialogue that happened. This was in the group of correspondence that we got from Deputy Kelly. There's not short emails, but quite extensive letters.
That may just be an error in the title, but the individual is obviously a consultant.
A doctor.
Yeah.
Yes.
So where does the Medical Council guidelines come in for that doctor and the other doctors that were dialoguing with each other and not with the individuals? Can you make a complaint, for example, to the Medical Council in relation to that? Because this is the absence of open disclosure. These are people that are governed by the Medical Council. They're governed by these guidelines. Does it matter? Is there a sanction?
So you're absolutely right that the ethical code under the Medical Practitioners Act, which was updated in 2016, is the guide that binds every doctor, and a failure to comply with the requirements of that can be a ground upon which a patient or any other person can make a complaint against an individual medical practitioner. So you're correct in that respect. But if I may just comment, I mean, I think some of what is being said here is a more general issue for the profession, where I think the profession itself in general terms has espoused and continues to do its commitment to the values of openness, honesty and open disclosure, and perhaps not every single part of the profession, perhaps not every single member of the profession has fully, if you like, discharged those obligations appropriately. And I'm not making a judgment in respect of this. I think it's very important that the profession on its own and in its own standing makes clear to the public and finds means of doing that its commitment to those values, because independent of the role of the HSE, independent of the role of the department, very significant societal charges are being made in a broad sense about the values that are ascribed to open disclosure, trust and honesty on the part of individual medical practitioners. And I hope that the profession can find a means through its collegiate structure and elsewhere of reassuring the public about its own commitments to these principles.
Yeah. And just to be clear, this would constitute a breach of open disclosure.
I'm not making a judgment on that, but if in an individual case the requirements of open disclosure weren't met under the council, that would be a ground for complaint that a person could make against an individual practitioner to the council. Yeah.
Okay. I want to. Another issue that came as a bit of a surprise, because to be honest with you, there's lots of numbers being talked about. There was almost 1,500 and then there was almost 1,500 and then there was another 1,500. Now I know that there's individual cases at two different groups in relation to an audit in one case. I'm not quite sure in the other case. There's confusion about the numbers where there was a relook. And I can understand that some cancers would present without people having gone and been screened, and there's nothing to look back at. We were told last night that there's 5 or 6 different categories, and I've seen that somewhere in some of the documentation that we got. Could we have some sort of a brief outline of just exactly what we're talking about in relation to all of the numbers that are out there? Because to be perfectly honest with you, it's very difficult to reconcile them.
I think it's a very good question, Deputy.
Kerry, can you come in from your side in terms of the overall national numbers of cervical cancer?
So what you're...
Speak to the microphone.
Yeah.
Don't mind who's behind you. Speak to
It's
the
hard
microphone.
not to make the eye
Yeah.
contact. It's a case of active registration versus passive registration. So the cervical check group does a passive registration of cancer. When they're notified, they log it as a cancer. What they don't do is actively go out to determine whether every person through the screening program has had a cancer. Okay? So that's their process. Our process is the responsibility to actively find cancer cases throughout the nation. And that's beyond the public. It's private and public.
It's kind of not getting to the question now I'm
So
asking.
that's the two different populations that you asked about, okay? So what happened was then we took data, their population, and matched it to the full population because they wanted to know who else had a diagnosis of cancer that hadn't been passively notified. So they had the people that were notified directly to cervical check, and then we gave them diagnoses that they had not received from their notification process. Those are the two numbers. We gave them approximately 1,600 other diagnoses, but those are lots of people who are older, not in the screening program, so that number would come down when cervical check matched our extra cases to theirs. I don't know the actual numbers because cervical check is doing that analysis.
Yeah.
Briefly,
Yeah.
If I may say, the independent clinical audit that's now going to happen, which will happen under the auspice of the Royal College of Obstetricians and Gynecologists, involving another organisation in the UK called the British Association of Colposcopists and Cytopathologists, they will have teams that will conduct an audit. They'll start with all of the patients that we know about through the registration and through what they call an algorithm, but a series of steps, identify those that need to be reviewed and review those charts and bring it right through to an end so that we can have, in broad terms, an answer for each individual person. And that will happen independently.
Yeah, there's people expecting phone calls that may not get phone calls and may have nothing to worry about. And I think part of what's causing the confusion is that there is a misunderstanding about some of the numbers and some of the groups of people. It would be very helpful if we could drill that down, how many lookbacks there were, what those categories were. When you're told that, you know, it's because somebody hadn't had screening, you can't look back on it, it makes perfect sense. And just people that maybe are older, it makes perfect sense. But I think with the numbers, the perception is that everybody was in the same one category, and that's certainly what I'm picking up. And I just think there's a bit of public information to be done in relation to that. I accept the point you're making in relation to what you've got to go through, but I think that there is a public information piece as well as.
Can I just ask Mr McCallum to just help very briefly on that?
So firstly, I agree in terms of the public information, the concern about numbers. The important thing here is these are all women who have or have had cervical cancer. There were the 1,400 that the cervical check programme went through, and 209 of those are the women that were identified that had a different interpretation. They were the immediate priority. The issue that emerged then was, in fact, there were a number of women on the cancer registry that the cervical programme had not made contact with. So that is the group that we've taken the data from the National Cancer Registry, and we're matching that through with the screening programme. That will come up with a number. It will be out of the total of 1,600. It will be a lot smaller, much smaller than that. We then had a discussion with the department without knowing the final number, and we would be asking probably the new review team that are coming in to prioritise those so that those women are contacted first to make them aware. All it is saying is that they've had cervical cancer and they were in contact with the screening programme, and we need to audit their smears as a result. It's not making a conclusion as to whether there was a difficulty or not. So they are the next priority, if you like, once we know who they are. And I think through the faculty process, the Royal College that are coming in, we want them to prioritise those early to bring certainty to them. But I accept it has been very complex with all of those numbers, particularly for women who are listening to all of this. Yeah.
I have two other questions. One relates to the HSE contract and the threat from, or the legal letters that happened initially in February. The HSE are the ones that are paying for this work. They're the ones that are setting the terms of the contract. was that something that was anticipated, the indemnity issue that they were seeking a confidentiality aspect? Can you just talk us through the control that the HSE has over a contract that they are the ones that have responsibility for? Because it doesn't make sense that the ones that are the people that are being contracted to do the work are pretty much dictating the terms of the contract. It tends to be the other way around. He who pays the piper calls the tune is a bit of a cliche from that point of view. And I do have one other question. Maybe you might answer that, and I just have that last question on just a different topic.
The contract was between cervicalcheck and the labs, and as with any kind of standard contract, there would be a dispute resolution clause so that you could invoke a formal process so as to be able to resolve an issue. But I'll let John Gleeson, if that's okay, who would have managed those contracts, speak to your question.
In terms of then indemnification, my understanding is that if a case is to proceed, then if it relates to a charge or an allegation against the laboratory, that the indemnification would be called in to indemnify the HSE, and the laboratory proceeds with its defence. If the HSE is also included in the legal proceeding, it includes with its defence, and it's the State Claims Agency and the laboratory, if it's included in the charge. It's a case by case. The State Claims Agency would really be able to advise better on this distinction, the indemnity and who indemnifies who, and who then deals with the plaintiff, whoever is bringing the charges. But I think that's not in relation to Dr. O'Keefe has said about the dispute resolution. That's pretty standard in any commercial contract. One side can take issue with the other, and you put in a formal process to sort it. That's separate.
Could I just ask, Chair, that you might that we might contact the State Claims Agency in relation to that particular aspect, in relation to the contract and the indemnity, because it does seem that we need to be looking at contracts into the future where there's where it doesn't hold up legitimate communication with patients. There can't be an impediment. But that we might make contact with the State Claims Agency and get some understanding of that.
But back to you who are signing these contracts, and the next time they're up for renewal. You're the people that signs the contract, not the State Claims Agency. So there's a responsibility on the HSE as well, but we'll do that. Then.
Just finally, last week when I asked the State Claims Agency were there other screening programmes where there were court actions initiated, and I was told there were 4 in relation to breast check. Now, are they in the same range in terms of what has emerged? We know there's 11 in relation to cervical screening. We don't know if all 11 relate to the same thing. Presumably that they do. The 4 in relation to breast check, is that to do with the screening programme? I see with a lot of the correspondence that we've got, there has been concerns about there's been suggestions that people with lower level skills would be taken on to try and make sure that there isn't there aren't delays in the programme. So do we know anything about those? Because once that number is out there and once that issue is out there, it has the potential of undermining another screening programme that is obviously another vital screening programme.
Maybe 2 points on that, Deputy. We've sought the list from the State Claims, and Dr. Coffey will come in a second, but of all cases against all of the programmes. So we've got a list, but that doesn't give us details in relation to the individual cases. So we've sought further information from them on all of the other cases. The 4 you referred to. And separately earlier this morning, when Deputy McSherry asked the question, we responded that in relation to the other screening programmes, not only is the external review looking at that in terms of Dr. Scally, but we're also bringing in some resource ourselves to look right across all the programmes across the entire quality patient safety, just to make sure, I suppose, and satisfy ourselves that we can do that. So we're still waiting details from state claims on the detail of those cases at the moment.
We were told last week, according to Deputy O'Brien, that they're on the basis of misdiagnosis.
Details, I'd be speculating. I got a list of the sort of case numbers and so on and details, but we didn't get the individual clinical instances, so we have to look at that.
Sorry, can you recall?
Yeah,
sure.
My recollection is when you asked the question, I followed up and I asked them what were the nature, and the information was given that the 4 of them are claims of misdiagnosis. And that will be on the transcripts.
Yeah, I think and there might have been a reference to the reading of the mammogram by the radiologist. Yeah, that's the only recall.
It's just that within some of the documentation that we've got, that we got it just earlier this week, there was quite a bit of discussion about delays, about shortage of staff, different delays in different parts of the country, are you satisfied? Are you satisfied that there isn't a problem with the screening programme at this stage in relation to your capacity to deal? I think it's important that we know that at this stage. We know that these will be historical cases if there's already court action has been initiated. But sorry, can I just get an answer on that?
Mr. Coffey has indicated.
Sorry, just 2 points there.
And then we're going on to Deputy McSherry.
Okay.
Sorry, Deputy Murphy. I don't need further detail to add on the State Claims Agency cases, but the correspondence you're referring to, I'm not sure what it specifies, but I am aware that there is pressure in the breast check workforce as the age extension from 65 up to 69 is implemented, finding enough mammographers. There is an international shortage, and there are very aggressive recruitment campaigns being run by breast check to try and meet those needs.
Right, can we go on to Deputy McSherry?
Okay, I'll come back to this again.
Deputy McSherry.
Thanks very much. There was a thing that came up yesterday with Vicky and Stephen that they came in, and I don't know whether it was covered earlier on. I know I was in and out. If it was, just stop me and I'll move on to my other questions. And that was in terms of looking at the efficacy rate in various labs and the percentage of tolerable error and so on. It was put that we look at the statistics, and that once that it falls within the percentage statistics, then that's that box ticked and we move on. And that do we need to be looking at the magnitude of the error and the consequence of the error in terms of how we act? Is there any assessment of that?
I think John did answer it earlier.
Did you cover that earlier on, yeah?
No, not in detail. No.
Do you want to cover it again then, John? Sorry for Mr.
Sorry, yeah.
Like an error is an error is an error?
Of course.
Or that error was a typo and this error led to catastrophic events. So are we just looking at it statistically, or are we analysing the impacts of different types of errors that are being shoved into the statistical percentage that's acceptable in international best practice?
We analyse the impacts as well. In other words, if it considers that it should have reported or could have reported a different result, what was the recommendation, which is the impact? It would recommend an earlier follow-up in some way, come back in 6 months for another test, or we refer you to colposcopy. If that doesn't happen, then that's your impact.
Okay.
That's the, I think. And the general standards you were saying, just in acceptable ranges, would be like positive predictive value. We want it up there high in the 80s. It is. It's scoring.
Dr. McCann mentioned that earlier on, but I just wonder, do we in our own right, do we just take the international statistics or the international practice as that's the way to do it, or do we look in a little bit more detail, you know?
So, Deputy, can I've asked the same questions myself, okay? In the short time I've had on this. I've taken some advice from one of our colleagues inside the screening service, and I'm going to ask Peter to maybe say a word or two in a minute. There's one factor that I think we need to be aware of, and that is that depending on the life or the time of the screening programme, when you do international comparisons, you must consider if something has been started fairly recently or if it's been running for 20 years. Because there are differences in terms of the detection rates and the downstream recording of high-grade versus low-grade instances. So doing pure international comparisons purely on the statistics and labs needs to be treated with a little bit of caution, and that's why I think the faculty that we have that we are constructing to provide advice on that, the review with the Royal College of Obstetricians and Gynaecologists will also be important, because we need to compare not just within Ireland, we need to compare against international best practice. And I don't know if Peter wants to say something about that.
I think that when you're moving from the population to the particular, which is what we're doing here, and this is what has fueled the entire controversy, we're looking at a very different thing from screening. My calculation would be that if you're a woman in Ireland, the chance of you dying of cervical cancer is about 150. If you're in the programme, one of the screened women, the chances goes out to about 1 in 10,000 approximately. So there's a huge, and there's a smear error causing that, by the way. So we're looking at a very select population here. And I'm not sure internationally what the experience is in looking at these failures. But it's an entirely different sort of a thing to do than looking at population-based statistics.
We could be pioneering over here, though, could we not? And show the world how it should be done? Dr. Honan?
The scoping inquiry, in terms of some of its remit, in other words, to look at the policies and procedures, are all the ones that should be there, were they all appropriately followed? So all of those are part and parcel in terms of reference of that. Yeah. And so your question is a fair one. And so it's at the heart of our considerations in putting together those terms.
I think we know the answer of that.
And the second part of it is the clinical audit, because that's a question that each individual person will have. And we have to be sure that we don't just have measures that track overall rates from a QA point of view, but also have capacity to learn from the individual circumstances, and that all the policies and procedures are fit for purpose from that point of view. Those questions will be answered independently through the processes that are in place.
I think I have those answers already. I think those answers are going to show us, and from the evidence we're hearing, are going to show us everybody did what they were supposed to do in their own little box. Everybody else in their other box thought it was tickety-boo because the person in the box next door was doing their job. And the outcome will be what? The outcome will be, well, there was a row going on between consultants and cervical check. The people didn't get told, and now we're in the mess we're in. I don't think the public are going to accept that as an outcome. But that's what I think we'll be saying in 2 years' time, or whenever a commission of investigation and the scoping report and everything is out, is that, we've heard from Dr. O'Keefe that, everybody feels that they did the right thing at the right time, but they didn't. Can I ask you, Dr. Honan, because we were all a little bit, I suppose, uncomfortable after you left the last day, and I was going into the studio on TV3 and I was handed a statement saying that you knew about the memos or whatever. You made this decision that it was fair and reasonable not to escalate to the Minister. If you were the Minister and your CMO made the same decision not to escalate, how would you feel?
I still would think it's a fair and reasonable decision.
That's tickety-boo, Doctor. I know you were doing the right thing.
I wouldn't say tickety-boo. I would understand it in the context of the general escalation environment. Yeah. So I would want...
Are there comparisons to other medical crises where it would have taken as long, or you took an independent decision not to escalate it? Say where people had died, or any of the other things in the past since your time even as Deputy CMO in 2001?
Yeah, and I don't want to waste your time now by going through the answer I gave earlier on, but I did set out a kind of a framework for kind of criteria. Right. Where,
there's a matrix where there's a matrix of when you escalate, is there?
So the biggest issue from our point of view, when we hear about something, is this a risk that tells us that a service might be safe and needs an immediate intervention, unsafe I should say, needs an immediate intervention. We've responded in those kinds of situations. Clearly we escalate immediately in those situations. If there's been a failure for people who've gone through that service and they've been exposed, and there are examples of that I could give you, and I won't waste your time talking through them, and patients have to be identified through a look back to be offered some service to help to mitigate and then the next level down would be if there's an individual case but that doesn't have wider safety ramifications, that still has to be brought to the Minister's attention. This is in the category at the time in 2016 of something that could potentially cause a difficulty. Every population-based programme, screening, immunisation, carries with it the risk that publicity arising from how errors are reported if there are cases. This is a well-known, internationally recognised phenomenon. So any screening programme carries with it an immunisation.
But then let's say
so if I escalated every potential risk that I'm aware of, if I escalated all the actual risks that I'm aware of, I wouldn't be doing my job. So my job is not to escalate. My job is to manage and to oversee managing. But I do escalate where that's appropriate. So
reading your bio, it says you have to advise the government.
Yeah,
absolutely. You advise the Minister for Health.
And I stand over the advice that I give. Yeah. In that context, it's a fair. So my job is not to tell the government everything I know.
But you seem also to be managing the information you choose to share.
So I make professional judgments.
You make professional judgments.
Yes.
Yeah. No, I appreciate that. But I just want to move on to Mr. Breslin for a second. There's monthly management meetings with you and the Minister and the Assistant Secretary who will be in charge or within the department who will be relevant to acute hospitals. Isn't that right?
Exactly, monthly. I think we every 6 to 8 weeks, I'd say.
So every 2 months, let's say. Okay, so 6 a year. Do you attend those too, Dr. Hall? Do you attend those meetings?
So we have a weekly management meeting, but yes, I'm in the same...
The one that the Minister attends?
Yes, absolutely.
Do you attend those meetings?
I do indeed.
Okay. So let's say the 12 meetings in the relevant period, this never came up? No remote? That thing is going well?
No, never came up.
It's not going well? Never came up once? Okay. Does the Minister always attend those meetings?
The Minister... I think pretty much if the Minister can't attend, they don't go ahead. So
they don't go ahead. So it's not as if the special advisor sits in, or did that ever happen?
Not to my recall was the senior minister absent from one of those. There may have been an occasion in the past where a minister had to leave early, and we stayed talking through some of the issues with a Minister of State, whatever. But the Minister attends.
Do you all feel that you have plenipotentiary status in your own relevant roles, that you're responsible for this and you make judgment calls, professional judgment calls on whether things are escalated or not?
I'm not sure about plenipotentiary. We certainly do a lot of work that we have to do independently and not be referring back all the time to the Minister. That's the nature of the amount of...
Yeah, you see, I mean, just again with Mr. Teague, what he said, yes, 18 people are dead, but it's not important enough to escalate it. You can understand people's frustration. From where I'm sitting, I'm sure anybody looking in could be forgiven for thinking the Minister's role is, quasi-ceremonial. He gets to stand in for the shot, but really, that's it.
That's not true at all, because if you take the discussions that we've had this morning about all of the work that has been done legislatively, the Minister has driven that agenda.
Yeah.
The previous Minister...
That's a good point, actually. So let's just look at that, and let's look at collective responsibility in ministerials about the non-commencement of Section 32B of the Legal Services Regulatory Act, which would have prevented some of the difficulty in this, and the non-commencement of, I think, Section 2 of the Civil Liability Amendment Bill in terms of periodic payments to victims. So both ministers have done splendid jobs in pushing that agenda. We had the announcement last week in terms of the package of measures, which was welcomed by our two guests yesterday evening, which, as of today, nothing has happened on. So they seem to be doing a great job at talking the talk, but when it comes to walking the walk, really it is about standing in for the shot. Although they are conspicuous by their absence over the course of the last week, where there's been a marked reduction in the number of shots or TV appearances. That's an aside. Can I ask... what changes have been made in terms of your approach to escalation, both of you? Actually, just one other thing. The Assistant Secretary of Acute Hospitals, your statement of last Thursday night said the memos had gone to the CMO's office and Acute Hospital. So that's an Assistant Secretary. He never, or she, I don't know who it is, but did they ever say it to you? No.
No.
Never.
This is all. On Tuesday, I placed all of this into the public domain.
No, I understand. I must have missed that because I was probably prepared for this.
I appreciate that.
Sorry if I did. But again, what do you talk about if you don't talk about this sort of stuff?
We talk about dozens and dozens and dozens of things that are either being developed by the department in order to improve the health services or issues arising in the health services. And as the CMO has outlined, the first objective that officials within the department have is to engage with the HSE on an issue, check out whether the issue being dealt with is a good issue. If they're going to do something bad, try and stop it. If they're not prepared to stop it, escalate it. If it's a good thing, support it. See are there any issues in it and manage the situation. And on occasion, and the CMO has outlined them, on occasion we absolutely do escalate issues. We have escalated dozens and dozens of issues. We go in, we find an issue with a service, we actually have to close the service down, we have to move something. We work with the HSC on this all of the time.
Okay, I get the
very,
point.
very serious.
Did the ministers, since this debacle now of last week and the professional judgment not to escalate, has the minister issued any guidance to you to say, gentlemen, I want to know everything from now on, or?
I don't see how a management paradigm that would involve the minister knowing.
No, I just asked. I didn't ask you.
Well,
I didn't ask you to tell me to justify my question.
He has not issued something along the lines of what you just said.
So there have been no guidelines from the minister since this debacle as to, should anything like this happen, guys, I want to know first thing in the morning or that night. There's been no new protocol put in place.
We have talked about.
You had a chat.
Beg your pardon?
You had to talk about it. You had a chat about it. You said.
We've talked about the relationship around this issue and how the issue was perceived in 2016 and the reality of what actually happened post 2016, and the fact that there were issues in 2017 that had we known about we would have escalated, which I've said straight up this morning.
Yeah, but I'm more talking about tomorrow if something happens. Has the minister introduced any protocol to ensure that he or she know immediately?
You can, and we do have.
I'd say it's a yes or a no.
We have protocols, but we also have.
We've established that the protocols, based on professional judgment, might not be in the public interest, as we would see it. So I'm just asking.
I don't agree with that. I believe judgment.
I appreciate you don't agree with it. I appreciate you, but nobody has exclusivity on being correct. So what I'm asking, based on the debacle of the last number of weeks, is have the ministers, the line ministers relevant to this area, introduced any new protocols, adjusted protocols, so that the same thing doesn't happen again? Or is it steady as she goes? We're happy enough how things work?
Preventing the same thing requires judgment. We cannot absent judgment from the management of the health services. It will always require judgment. Otherwise, it's artificial intelligence.
I can only say, you know, in my humble, lowly backbench opinion, had I been a minister while all this was going on, I think one of the first things I would have done is say, Secretary General, CMO, from now on, I want a list every morning of what's going on. And I've simply asked the question, has the line minister introduced any new protocol or directions?
I think I've answered your question.
No, it's a yes or no. You haven't.
I think I've answered it.
Is it yes or no?
I've told you that no new protocol has been issued.
No,
I've answered
okay,
your question.
you've answered the question. The question is no. Am I done?
You are.
Okay, thanks.
And the next speaker will be Jonathan Ryan, which is one question. I missed what you said a minute ago about the escalation to the minister. You're saying if you had known now, or if you knew then what you know now, you would have escalated this issue. What exactly were you referring to?
The widespread non-disclosure of the information to the women. And in fact.
Okay, let's go through this now. We're back into an important issue again.
Yes.
So you say it.
So as soon as we learnt of that, the serious incident.
No, don't say that. As learnt of what? I just want you to say.
Sorry, the widespread non-disclosure of the information to the women.
And that's the 80% of the 200.
Yes.
Right.
Yes.
So you became aware of the non-disclosure of the 80% of the 200. The patient hadn't been notified of that.
Yes.
Around the time of the court case.
In two stages. Immediately post the court case, we understood there to be a problem, and then once the serious incident management team over the course of a weekend traced the 208, as it was then, cases, and we found 44 of them had been, was it 44? 46?
Approximately 20%.
Yes, then we knew this was widespread.
So here we are now. We're at a crunch of an issue here, I think, listening to what's been said at the meeting. You were saying as Secretary General and as Chief Medical Officer, had you known quite some time ago that 80% of these cases had not been notified to the patients, you would have escalated that information to the Minister.
Yes, and not just to the Minister. We would have escalated with the HSE. It would have formed part of our performance dialogue. We would have had it as a top-level issue in terms of our engagement with the HSE management team.
So, I have to ask you, as accounting officer, who's ultimately responsible for the 15 billion of a budget that our office gives you to spend wisely on our behalf. So, seriously, there was a very serious breakdown in information getting to you in relation to the non-disclosure of information to 80% of the 208 women involved at only emerged recently. That information could or should have been known about, wasn't known about. It goes without saying, if you consider that, the knowledge of that, such a serious issue that had you known you would have escalated it to the Minister promptly. You must be seriously regretting the fact that that information wasn't given to you at an earlier date.
Absolutely.
Would you think that that was one of the most serious failing in this whole
It's a very serious failing because, A, the very fact that it had happened is a serious issue which we all regret. But secondly, the need to address all of the type of questions that people have asked and all of the issues arising and the uncertainty amongst women in relation to that would have been to the fore. We would have mobilised the response and we would have started to get ahead of the issue instead of, as people have said, reacting to events that made their way into the public domain.
So just to go back to the Chief Executive of the HSE or the interim, we're now hearing the information about the patient was within the HSE that people needed to be informed in 2016, early in 2016. Mr. Breslin is saying, had he known after a short period of time that that hadn't happened, it would have been a matter so serious as required escalation to a Minister. So the fact that that situation wasn't acted on, not talking about you personally, the fact that that situation wasn't managed and the facts obtained during that period that the patients weren't actually informed, Mr. Breslin considers that a very, very serious issue because had he known that, it would have been straight into the Minister the next day he was in town. So there's a serious failure within the HSE not to monitor the fact that the patients were not being informed. Mr. Breslin saying it was so serious, had he known about it, he would have informed the Minister. You take the point now, and we're trying to put, we're trying to make Mr. Scally job easier. We're putting a bit of responsibility. Yeah. We're getting to the kernel of the non-collecting or the non-followed through of a situation that was well known in the HSE that Mr. Breslin has said what he said. He should have known it, and if he had known the situation, he would have moved on it.
And I think that sentiment from Mr. Breslin would also apply to some of my colleagues here as well. Yeah. If they had known the scale of this at the time, then they would have taken action. In terms of escalation, I would expect that a manager would actually deal with it without actually having to escalate it. They would only need to escalate it if they couldn't actually deal with it. Yeah. Yeah? What was the point in escalating and extending the timescales if you've got actually the wherewithal to solve the problem yourself? Yeah. So I think escalating, which is passing the problem up, okay,
I understand that.
Sometimes isn't the best thing to do. I think we need to have a culture imbued to say, this is your issue, you need to deal with it forthwith.
Right, so essentially this problem is there wasn't a system put in place by the people in charge in the HSE to be on top of this during that 2-year period.
I think I've captured it using common parlance, which was there was no feedback loop. There was an assumption that it was happening, okay? But clearly that assumption was wrong. And perhaps the lesson we need to learn here is we actually need an audit trail that says, if you've got an action, then have you closed out that action? Yeah. And is it done? And when is it done? And whose responsibility is it to complete it?
Okay. Thanks. Deputy O'Brien.
Thank you, Chair. Chair, I want to not do the work of the scoping inquiry. So I think they have a job of work to do, so I'm going to ask a couple of questions. Just in relation to the memos, we know there's 6 memos. February was the first, October was the last. And the last memo in October, I mean, it starts off, the one in February talks about the labs looking at legal advice and the 4 steps, and I can understand the rationale behind all of those steps when you put it in the context of what was happening. Because the issue was not the audit process. The issue was the communication of the results of that audit process to women. So the very last memo, which is in October, says that there's an engagement between cervical check and the consultant doctors, which is going to be an ongoing process to inform women. Then, as Dr. O'Keefe has said, that the communication with the stakeholders and the patients is being appropriately managed at this time. So at that stage in October, is it fair to say that Mr. Houlihan, Dr. O'Keefe were of the opinion that this was being addressed, women were going to be informed, that was the instruction that was given, all women were to be informed through their clinicians, and that was your understanding, and as far as you were concerned, there was no need then to escalate it up the line. Is that a fair assessment?
Yes.
Okay. So then obviously we now know that there was a breakdown in that. Clinicians did not inform women. Is there anyone in this room, and obviously Mr. Houlihan and Ms. O'Keefe said that they didn't become aware of it until recent weeks when this all came out and post Vicky Phelan's case. So there must have been somebody aware in those intervening periods where there was an understanding that all of the women were going to be informed through their clinicians. That was the policy, open disclosure, inform everyone. And then we find out when the Vicky Phelan case becomes public knowledge that that didn't happen. So there's a period in there where somebody must know that that wasn't happening, that there was ongoing correspondence between the clinicians and cervical check in terms of who was responsible or who was the most appropriate to inform the women. Is there anyone in this room who is aware of those difficulties?
We were informed around about July of last year that there was difficulties in communication between the screening group and the doctors concerned.
Okay. And who informed you of that?
We were informed through the Limerick clinical director,
which is the notes we have.
Yeah.
Which we have the notes there. So the first that anyone in this room, in terms of the HSC, cervical check, or the department, became aware was in July 2017, which from October to July there was no knowledge of any issues in terms of clinicians not relaying that information.
Well, the first time it was communicated to Dr. Henry or myself was in
July 11th.
July, yeah.
Okay. And what did you do with that information then?
Well, when the information came in, we got it from one side. We got it from the clinicians. They said there was a process here that they weren't happy about. They gave their side of the story. So the first thing that we did was to undertake to hear the other side of the story, which was to write to the screening and get the reply.
And that would have been Grania Farrelly, yeah? Okay. So then it comes back to cervical check. Was that the first time, Mr. Gleeson, that you were aware that there was an issue between clinicians not informing their patients?
No, I don't think so.
So when did you first become aware that there was an issue?
I don't have a date. Dr. Flannery would have commented over the months from October 2016 as the historic letters, the dated cases going back had all been cleared, and we were now in current mode. As a case arose, we were communicating that she had had a chat with some clinician they'd met at some of this, they might have discussed the case or whether or not, but it was proceeding. She wasn't raising any issue until the particular one that Dr. McKenna refers to, where there was a serious block, and we discussed it at the executive management team and said we'll try to go to work on that and release that block. We can't have that.
So between October and July, you would have been aware that there were some issues, but it wasn't a major issue, and it wasn't until July when you got the correspondence from Limerick that you realised, hang on, this is a major issue here.
It was one clinician, but it was, yes, there was a number of cases. So
in July 2017 then, was that not escalated further up the line that there is a major issue here?
In the first instance, Dr. Flannelly undertook to address